we'll continue the talk that I was giving last time, which was a case discussion based on endoscopic CSF diversion. My original intent was a case presentation followed by some basic principles of how to set up an endoscopy case, and also some basic aspects of ventricular anatomy. Unfortunately, I didn't time myself quite well, so I was only able to get through the case presentation. I couldn't actually review some of the materials that I wanted to. So in the first few minutes, I'll quickly go over the case presentation, and then I'll go over the questions that I wanted to review with the residents and with the audience. So the case was a 10-month-old new presentation with poor oral intake and emesis over the preceding several weeks, with disconjugate eye movements. On initial evaluation in the ER, his hip circumference was slightly high on the 75th percentile, with a full fontanelle on exam. His vitals were stable. At that time, the ER did a single EEG examination, which was negative. They actually got a quick stroke protocol because they were rather worried about this child. And the anatomical scans here showed that his ventricles were maybe prominent, but certainly nothing to write home about. And the vascular sequences, although certainly not detailed, did not show any obvious venous and or arterial abnormalities. The child was observed for a couple of hours in the ER. A basic chemistry panel and a CBC panel was unremarkable. The child was feeling somewhat better. He was discharged home, but then unfortunately bounced back 2 days or a few days later with similar symptoms, which had progressed. So now it's about a week. The child is still not eating well. This time the ER calls in the ophthalmology service. They do a dilated eye exam and document papilledema. For some reason, as the ER does sometimes, unfortunately, they also called the hematology service, who actually did to do an LP, which showed that the opening pressure was 32, and the hematology service, in discussions with the ER service, actually started Diamox on the child. The ophthalmic evaluation was also significant for 6th nerve palsy. So he has papilledema, 6th nerve palsy, a high opening pressure, and has been started on Diamox. At this time, the child was admitted and underwent this detailed anatomical study. These are the non-gated T2 sequences. The axial cut shows the optic disc that's prominent, that's consistent with their bedside examination. Very importantly, the sagittal reconfiguration shows that there is no obvious obstruction either at the level of the aqueduct or at the fourth ventricular outflow. So no obvious anatomical obstructive pathology, but certainly persistent symptoms, and the ophthalmic evaluation that I just described. So the assessment is consistent with raised pressures, no obvious etiology, and that's when they consulted us for the first time. And I suggested we place an ICP monitor. The LP can sometimes be a little hard to interpret, especially in terms of a single opening pressure. Before we do any definitive treatment, I thought an objective CSF, an objective ICP measurement would be useful. So we placed an ICP monitor, and sure enough, his pressures ranged in the high 20s to low 30s that same afternoon and overnight, and by next morning, he was consistently in the high 20s and low 30s range, which was consistent with raised pressures. So he has now documented high ICPs. He's symptomatic. sixth nerve palsy, the symptoms that I described, papilledema. So we decided to treat him. The options, I quizzed the residents last time. Someone suggested ETV, someone suggested a shunt. Um, to be honest, I'm more dogmatic about some of these things. In usual circumstances, for non-obstructive pathologies, I would not have suggested an ETV. But this is a really atypical presentation. I didn't necessarily want to commit the child with a shunt for the rest of his life. Proving shunt independence at later points in time is very, very difficult. So I thought I would start off with an ETV. The child is admitted. We have an ICP monitor in his head. If the ETV works well, we'll know. If the ETV is not working well, then we'll just bring him back and put a shunt in. The parents were okay with the plan, so we went ahead and planned for an ETV. Basic setup for an endoscopic procedure, an ETV is relatively straightforward. Anyone from an R2 onwards should know how to do an ETV. The actual mechanics of it are not complicated. There's certainly some decision making involved, but the basic things that you need an endoscope. The basic workhorse, so as to say, is a 0-degree scope. Here we use either a little LOTA or an Escalab scope. You need a monitor to visualize what you're seeing. You need a camera to actually capture the images. You need a light source to visualize what you're seeing. Cautery is not necessarily needed for an ETV, but you should always have it on hand, because if you have bleeding, it's helpful. And then you need an irrigation device. Now, the irrigation device can be as simple as a bag of saline hanging on an IV pole, or it can be something more sophisticated like the one that we use here, which is a motorized pump where you can actually regulate the flow rate. Um, Additionally, we also use some dissection instruments, not necessarily relevant to this case, but important to keep in mind if you're thinking you might be doing a septostomy, or you may have potentially a tight foramen or some altered anatomy that might require some additional maneuvers. We don't always need neuronavigation, but certainly since all our children, or sorry, all our patients undergo a detailed scan, it literally takes a couple of additional minutes during setup to register the child and have it available, and I think it's very useful. Ultrasound we don't usually use unless the child is really young and has a big open fontanelle, but you can certainly use that too. It's actually quite helpful. So two main scopes we use. One is a flexible fiber scope. This is the Codman scope that we also have. The big disadvantage of a flexible scope is that the picture quality is quite low, although it's way better with some of the newer scopes that we've bought. The working plane can be difficult simply because the flexible fiber scope is basically like a spaghetti noodle. So since it's moving around too much, it can be to your advantage that you can reach into small spaces and through tight foramens, or if you want to navigate corners, especially during a choroid plexus coagulation, it comes in really handy. But it can be hard to manipulate in terms of working planes if you're actually doing any dissections or any additional maneuvers. Because the flexible endoscope is small, the port that you see here is obviously small. So the only instruments that can go through are these thin flexible instruments that are, again, useful for basic maneuvers, but you can be limited, for example, if you want to do some intraventricular dissection. On the flip side, you can turn corners. This is really important and relevant when you're doing a choroid plexus coagulation, and when you need to turn the corner from the lateral ventricle and go down to the temporal horn and coagulate the choroid plexus in the temporal horn. Again, it's small and it can maneuver itself through small spaces. For people who are really experienced, and that does not include me, You can hold the flexible endoscope in your hand, but generally speaking, what's most useful is to use this clamp system, which is what we use here. This is our setup here at AFCH. Other places have this. Same principle. You cannot clamp the flexible part of the scope. That will basically crush the fiber optics. You can only hold the camera. So this is basically a flexible Greenberg that's holding the camera. Most of these kids are obviously very small in size and weight, so you can't really put this big bulky camera on the patient. It's just not practical. So the rigid clamp is actually very useful to stabilize the camera. So you don't need it frees up your other hand, and you only then need to use one hand to manipulate the fiber optic inside the brain. That's important. The other scope that we use, the Escalap, is our racehorse, our workhorse, excuse me. So as to say, most of our work is done with this. Um, it's a rigid rod lens, so it has way better image quality. Again, the working channel is much bigger, so you can pass off bigger working instruments through it, and you can do much more formal dissection with this if needed for your case. Obviously, on the flip side, because it's fixed, you can't really maneuver tight anatomical spaces. So some of the instruments that we use in addition, we have these coagulation devices. Some of them are straight, some of them have these fancy curves on them. This is sometimes important, more so for ventricular dissection. Again, not necessarily relevant to the ETV case that I'm describing, but helpful for the residents to know. Most of the rigid working instruments will have a function where you can rotate the angle of or the axis of the surgical instrument, and that's really helpful so that you can maneuver the orientation in which you cut or dilate or do any particular maneuver. And this is basically a magnified close-up of some of the rigid instruments that we use. So orientation during the case, anatomical and surgical orientation is extremely important. And I showed this image and I asked the residents to identify the surgical coordinates, and most of them had trouble. So the reason why most people would have trouble, and to be honest, I would have trouble, is because this image is not oriented properly. And the reason why this image is not oriented properly is that most of us, for a standard case, when we're doing an ETV, would cannulate, would establish right frontal axis. So you would, make your burr hole and you would access from the right side. And when you cannulate the right frontal horn, this is not what you expect to see, right? You expect to see that the septum would be medial. You would expect the choroid plexus to go from medial to lateral. You have a particular orientation in your mind, which is your mental map of what the anatomy would be. The reason why this picture looks funny is that when I initially presented the case, I mentioned more than once that you were starting off with a flexible endoscope. This is a really important point. A flexible endoscope in itself does not have any orientation. It's, as I mentioned, it's basically like a spaghetti noodle. You can twirl that flexible endoscope around and the same image will rotate clockwise or anti-clockwise, right? So this orientation is, and I'll come back and I'll elaborate on that in just a bit. So disorientation is a big problem because you can use your stealth and the stealth will tell you that you're at the foramen, but it's obviously not going to help you identify the anatomical landmarks, which is the first step that you need to do to navigate through the foramen and get into the third ventricle. So why does disorientation happen? Um, some of it has to do with how the operative setup is. You're extremely magnified, and your surgical view is focused at the distal end of the endoscope. So that's obviously an advantage of using an endoscope, but it can be really disorienting because now you're looking at a really zoomed up picture, and before you get experience into some of these procedures that can be somewhat disconcerting. The angle views can be a problem too. With a 0-degree endoscope, which is basically a fixed, and the one that we use as an Escalap or little Lotta scope, disorientation is less likely, but with a 30 or maybe a 70-degree scope, that can significantly change the angle at which you're viewing your surgical view. So you could turn the 30-degree up, or you could turn the 30-degree right, left, and instead of seeing a spot on image, you'll be looking at the left corner, the right corner, or the bottom corner. So the angle view or the scope orientation is extremely important to be cognizant of when you're trying to match what you're seeing at the endoscope with what your own mental anatomical image is of that surgical view. And obviously, there are patient factors. If you have a tumor, or hydrocephalus, or scarring, or previous surgery, or whatever the patient unique factors are, then that's going to distort the anatomy further. Um, the third, but certainly not an infrequent reason to be disoriented is when you have bleeding. When you have bleeding, all what you see is basic red in your blood in your field. So and I'll go over some of the basic steps that we follow when you run into bleeding, but that can also completely throw you off. So how do we avoid disorientation? Obviously, know your anatomy. Sounds very cliched, but that's the basic step. Know what you will expect in this case when you go down the frontal horn and you're at the right foramen of Monroe. Know that you can have some variability in ventricular anatomy. No two foramens look exactly the same. No two third ventricles look exactly the same. So know how the patient relevant factors can change the mental anatomical landmarks that you have. If there is patient dependent variability, have some basic important landmarks that can never go wrong, like midline, for example, or choroid plexus. The veins may be altered, the foramen may be small, may be large, but you've got to have some critical key landmarks that you know will always be where they are. So that can be very helpful. And once you have your primary coordinates using the primary landmarks, then you can reconcile what your secondary landmarks are. Very importantly, especially for example in the earlier image that I showed, um, if you've just cannulated the ventricle, you're a long way off from making your ETV stoma, and you're still disoriented. Stop. Don't just blindly keep going forward, because that's just going to cause problems. So bear with me. This is my artistic rendition of illustrating how a flexible endoscope can throw you off. So obviously, anyone reading this clock will read this as a clock showing a time as 10 o'clock. If your flexible endoscope is oriented neutrally and looking at this clock, then certainly you will also see 10 o'clock. If you rotate the scope and just turn it clockwise, then that same image in your mind is obviously going to read the time as 2 to 20. If you rotate that endoscope further clockwise, then even though the patient's anatomy hasn't changed, the view that you're looking through with the endoscope has now switched further to 540 in this case. If I keep on rolling that endoscope, remember it's a flexible spaghetti noodle. It has no orientation itself. The only fixed clamp that you apply on the fiber optic scope is only on the camera. So if you keep turning inadvertently, or if you're not oriented correctly, and if you keep flipping that flexible fiber scope and you keep going round and round, then that same image, which is still 10 o'clock, will be viewed in your endoscope camera as, in this case, for example, 850. So this is really important, the patient's actual anatomy has to match the ventricular view that you're viewing. And that can only happen if your flexible endoscope is oriented neutrally. So a very simple way of doing this is simply to, in this case, for example, take a suture pack, or usually I just put some sort of a label next to the bore hole. So every time I put a flexible endoscope, I check the orientation, or any means that you want to use, but make sure that when you're putting the flexible endoscope down into the burr hole or through the access port, then every time you check the anatomy, and obviously as you get more experience, you'll be able to adjust for that without knowing it. But for people who are not cognizant of this, it can lead to major disorientation. So this image was actually this image all along. And if I had shown this image to the residents, then I bet most of you would have had no trouble in identifying the landmarks. Obviously, this is midline, right? Because this image now matches what you expect to see for the right foramen. You would expect to have the midline here, lateral, anterior, posterior. Hopefully, you can all see my mouse. If this is the septum or the midline, then this has to be the septal vein. This will be the fornix. The caudate will be here, and we'll talk about the venous structures in just a bit. So the reason why the same image flipped from here to here is because you basically reoriented and made sure that your flexible endoscope was in a neutral position. So that's a really important point to keep in mind. Most of us, for most uncomplicated cases, will usually start off, especially in adult cases, with a 0-degree rigid scope, so you don't have this problem. But in, for example, pediatric cases where if you're combining this with choroid plexus coagulation, you'll inevitably have the flexible endoscope on hand too. Or if you have really small ventricles, or some other reasons that forces you to use a flexible endoscope, make sure that the orientation is matched correctly. So what do we see here? So we are obviously seeing the foramen of Monroe. That's the septal vein. The choroid plexus in this case is somewhat exuberant, but you can still see the caudate vein, which should be at this lateral corner, and the thalamostriate vein that should be at the posterior end. And these would all converge at this epicenter, which would be the venous angle. So let's review the ventricular anatomy from the endoscopic standpoint. I think that's really important. Um, Even though we're doing an ETV and you'll go from the frontal horn and through the foramen into the anterior third ventricle and through the floor, but in a larger sense, it's helpful to review some of the more basic aspects of the anatomy. So we divide the lateral ventricle into the frontal horn, body of the ventricle, atrium, occipital, and then temporal horn, respectively. So the three important features, and this is all from Roton's excellent chapter on ventricular anatomy. The three key anatomical features that the residents need to keep in mind when they're trying to orient are fornices, the caudate, and the choroid plexus. And it is the interplay of these structures that will help define the margins of most of the anatomical compartments in the ventricles. So all of them have a C-shaped configuration, right? So the fornix right here, the same for the caudate, head, tail, excuse me, wrong image. Head goes down through the body into the tail, and the same thing for the choroid plexus, starting at the foramen, going through the body, atrium, into the temporal horn. So what does so going back to the frontal horn, I tried to review this with the residents. Some of them were able to pick up correctly the anatomical boundaries, but to review this for everyone, the roof and the floor and the anterior wall are all defined by the same structure, because the same structure basically would initially make up the roof. In this case, that would be the body of the corpus callosum, that then makes the genu. So then that gives you the anterior wall right here. and then it flips down and makes the rostrum, which then creates the floor for the frontal horn. The medial wall would be made up by the septum pellucidum. The lateral wall would be made up by the caudate, and that helps define the basic anatomical boundaries for the frontal horn: roof, floor, anterior wall, medial wall, lateral wall. And this is a nice correlation between a gross specimen and an MR image. So this is kind of a grainy image, but unlike these days when residents have nice colored images in their boards, uh, we used to get printed board questions, and some of them would actually be in black and white. So these alphabets obviously label different structures of the foramen of Monroe. A is the thalamus-striate veins. I quizzed the residents on this earlier, so in a manner of review, I'll just go over them one by one. But A is the thalamus-striate vein. B is the choroid plexus. C is that small superior choroidal vein that runs right under the choroid plexus, and further back or if you divide this further, you run into the internal cerebral vein. The septal vein is obviously around the septum medially. This is the fornix. The anterior caudate vein would be this structure right here, and then anterior to posterior would be the caudate and the thalamus, and these are some superficial veins right here. So basic anatomical structures that all residents need to know, and please do refer to that chapter. It's probably one of the best chapters he wrote. So variability in the foramen, you can have small foramens, large foramens, scarred foramens, redo foramens, foramens affected by hydrocephalus, for foramens not affected by hydrocephalus. And this gives you some idea of all what you can see when you cannulate that frontal horn. And again, orientation is key. Know the anatomical landmarks, and for the residents, know the anatomical boundaries. Make sure you're oriented correctly, and you should be able to navigate through and in this case go through the foramen safely, and then enter into the third ventricle. There is some variability in the venous anatomy. So this is a really zoomed up image, but again shows you the septal, the thalamus-striate vein, the superior choroidal vein, and the internal cerebral vein, um, uh, and shows you how if you open up the fissure, you can actually open up the foramen more posteriorly for some uh, more involved ventricular techniques. So now that you've navigated through the foramen, you drop down into the anterior third of the third ventricle floor. So the third ventricular floor, most of us are somewhat biased towards only concentrating here. Obviously, we see the mammary bodies, we see the infundibular blush, and then the stoma is made right behind the infundibular blush in front of the mammary bodies. And in the majority of patients, especially for first-time ETVs, that's usually not a problem in terms of navigating the anatomy. But some basic things to keep in mind. These are the structural landmarks that we reviewed in that talk. So A is the anterior commissure, B is the optic recess, this is the optic chiasm. Don't mistake the optic chiasm for the anterior commissure and vice versa. The infundibular recess is right behind the optic chiasm. You've got the tuber cinereum and then the mammary bodies, and usually the infundibular brush is just about right here. Again, important things to keep in mind. This sagittal view actually shows that really well and orients you much better perhaps than that image. So again, anterior commissure, lamina terminalis, you've got the optic chiasm, optic chiasm and the two recesses that we talked about, the optic and the infundibular. I haven't, but certainly some experienced neurosurgeons will, if the primary ETV does not, primary ETV site does not work too well because of scarring or what have you, may sometimes make a stoma in the lamina terminalis. So that's why it's important to be familiar with the anterior with the anatomy of the anterior third ventricle too. It can be a salvage, salvage pathway, so as to say, for a secondary ETV stoma site. So once you make the stoma, you see the basilar artery. You want to see a basilar artery and a prepontine space that does not have any scarring, and uh, that's probably one of our most important prognosticators for ETV success. I think most residents should know that. So once the ETV is done, we can maybe review the anatomical features of the other parts of the ventricle. What's relevant here specifically is the lateral ventricle, and I'll also review the anatomy of the atrium. So again, body of the lateral ventricle will have four anatomical boundaries: the roof, the floor, the medial wall, and the lateral wall. So again, it's the corpus callosum right here that makes up the body of the corpus callosum that would make up the roof. The floor would be made up by the thalamus. The medial wall would be made up by the septum and the fornix running right around it or next to it, below it. And the lateral wall would be made up by the caudate body anteriorly and maybe parts of the thalamus posteriorly. So again, basic anatomical landmarks that the residents should be familiar with. So the anatomy of the atrium is important, not necessarily from the standpoint of the ETV procedure, but it's important because obviously, in addition to the frontal access point for our shunts, the other access point for our shunts are posterior shunts, in which we cannulate the atrium and then advance the catheter further into the body or the frontal horn. So the atrial anatomy is a little bit more complicated because there are more structures here. The anatomical landmarks are defined again by the roof, the floor, the anterior, medial, and lateral wall. So excuse my squiggly lines, but it'll hopefully help you orient the different anatomical landmarks. The corpus callosum make the roof, so that's still riding on top of the atrium. The floor would be made up by the collateral trigone. So the collateral trigone is, as the name suggests, tri. It's at the confluence of the body, the occipital, and the temporal horn. The medial wall is made up by forceps major, which is one of the major white matter tracts that cross over posteriorly, and the calcar avus, which is the indentation of the calcarine sulcus. That's really important to bear in mind, and I'll circle back to this point in just a bit. And then the lateral wall, which would be made up by tapetum, which are white matter fibers, and the tail of the caudate. The anterior wall is a little hard to visualize on that sagittal view, but this anatomical view and this small inset shows you the orientation of the image. So you're looking directly into the atrium. You would be staring into or at the posterior aspect of the pulvinar and parts of the fornix. So anyone and everyone who's put in enough number of posterior shunts will have horror stories about how these posterior shunts can potentially create havoc, right? So these anatomical landmarks are actually really helpful for the residents to know, to realize some of the potential havoc that can be caused by catheters that can go off target. So the calcar avus obviously is right next to the calcarine sulci. So you could potentially get into the primary visual area if your catheter indents the medial wall too much. If you are not careful about the trajectory and you end up through the pulvinar into the thalamus, you can have a very bad thalamic injury. So that's why it's really important these days we usually have an endoscope, so we know usually where we are going. We often have stealth, so your anatomical landmarks are verified not just by your experience, but with the help of neuronavigation. So this does not happen as frequently, but important to keep in mind that when you're doing a post-hoc check on these patients, always check their motor function. So you didn't bang into their posterior capsule or their thalamus. Always check their visual fields um, uh, and make sure that you didn't injure parts of their visual cortex. Again, your index of suspicion for that would be high if you were struggling in the middle of a case without navigation and or dealing with altered anatomy. So this was a step of the ETV that I reviewed earlier. If you suddenly realize that your field has turned red, it obviously indicates that you have bleeding within the ventricles. Um, a lot of times the bleeding is close to where you're working, but a lot of times it's actually behind where you are because you've inadvertently torqued the arm of the endoscope against maybe the foramen or a more posteriorly located target. The first thing to do is obviously to irrigate. Here we have a pump, but as I mentioned, even a regular saline bag under gravity is used at most places. The first thing is to flush. The second thing is to try and navigate and find out where the bleeding is. You can stop the bleeding if you keep some water jet pressure really close to the bleeding point. You will hear time and again from most people that with enough time, the bleeding will stop with irrigation, especially if it's like choroid plexus or maybe some ependymal bleeding. If unfortunately you've hit a vessel, then you may have to maybe use coagulation judiciously if you think you can safely do it, or just wait, or well, I don't know if it's a major injury, then you may have to think of a plan B. So usually irrigation will do it. You have to find the source, keep the irrigation jet really close to the bleeding point, and use coagulation if you have to. And with the combination of all those, almost always you will be able to control the bleeding. So during that same presentation, I reviewed another potential complication of intraoperative or postoperative complication, which was seizure. I explained the scenario where you drop the child off in the PACU, and the nurse calls you and informs you that the child is seizing. I think there's been at least one talk that Eric gave in terms of seizure management, so I won't spend too much time on this. Uh, Try and develop, and this is for the residents, try and develop some sort of an algorithm in your mind in terms of first, second, and third tier medications. Hopefully, by the time you're going to a third tier medication, you have the help of a neurologist and most certainly the help of an anesthesiologist to intubate the child. But usually, in children who are big enough, usually more than 10 to 12 kilograms, 2 milligrams of Ativan as a first line drug would work really well. If you have a really small child, then you obviously have to dose it based on body weight. Diazepam 0.2 milligram per kilogram is a handy dose to memorize and know in your mind because it's based on body weight. If the first line does not work, then you can either Keppra, which is usually 20 milligram per kilogram, or you can use phosphonate, which is usually 15 to 20 milligram per kilogram, followed by a loading dose. If the second line fails, then usually you're talking about either trying one of the other. So if you used Keppra, you try the other, or if you use Dilantin, you try Keppra. Or if you really think the patient is in status and you're having a hard time, trouble controlling airway and controlling seizures, then you need to intubate again. This ABCs intubate and potentially start the child on a propofol drip. Hopefully by that time, the neurology team is already involved. These three different bullets just basically represent first, second, and third tier medication changes. So that's it about that case. The main points were basic principles of setting up the case, what you would ask the nurse to set up for. This is probably a common scenario that you might get quizzed on boards. So it's helpful to know, in addition to the mechanics of how to do an ETV, what goes behind the actual setup and what instruments to request and such. The other really important points were obviously the anatomical landmarks that all the residents should be familiar with, both in terms of the ventricular view and then obviously gross anatomical views. In the remaining maybe 15 minutes, I'll quickly go over a second case. For this one, since I didn't discuss this with anyone.
Heel?
Yes.
I missed your first presentation back in April, but why did you do ETV as opposed to shunt in this child with communicating hydrocephalus?
So I was favorably inclined because of his age. He's 10 months. The cutoff is usually 6 months where we think success is lower. I didn't necessarily want to give him a shunt for life for a reason that didn't seem clear. I mean, he has high intracranial pressure without any etiology. He's not a premature baby who has post-hemorrhagic hydrocephalus. Doesn't have spina bifida. Doesn't have any vascular abnormality. Doesn't have any obvious abnormality that I can put a finger on. So instead of giving him a shunt for life, I wanted to see if an ETV would work. And actually it did. And thank you for reminding. What I didn't mention just now was that I left the ICP monitor after I did the ETV, and his pressures came down, and 2 days later or a day later, I pulled the monitor out and sent the kid home. And more recently, I saw the child in follow-up. He's doing really well, hasn't required anything else. So you're absolutely right to raise the point that it should not work for communicating hydrocephalus, but I was using it more as a first-tier treatment before giving him a shunt for an etiology that I just could not put a clear finger on. The other thing to point out is that even though his raised intracranial pressures were quite transient, only for that week, he was unfortunately left with a 6-nerve deficit. So he's actually, and despite the ETV treatment, even though the pressures came down, his 6-nerve palsy didn't get better. So the oculoplastics team is actually going to be doing. They were waiting for him to be old enough, but they're actually going to do a correction surgery on him. So even transiently raised high pressures can certainly have long-term neurological consequences.
Thank you.
So Mark, since I did see your name, I don't have the full list pulled up here. Maybe I'll pick on you. So there's a 12-year-old girl who shows up in clinic. She's got a 6-week history of headaches. They're partially exertional, but a lot of times will happen at rest, and she's quite badly affected by it.
Is she otherwise healthy?
Right now, she's healthy. She goes to school. No recent major medical illnesses.
Okay. And does she describe any other types of exciting activities or anything that cause the headaches, sneezing, coughing, or anything like that?
Right. So so they are partially exertional. You know, sometimes when she's active, this headache flares up, but a lot of times she'll have headaches even at rest.
Okay. And any visual issues? Any other like just the neurologic review systems, changing the vision, weakness, arms or legs?
No, so in the review of systems, she doesn't describe anything, but when you examine her, she does have a reduced gag and she has breast reflexes. the exam is otherwise normal. You did a fundoscopic examination. Her eyes are okay.
Yeah, I think, just given the overall story here, I think that one of the leading things on my difference would be Chiari malformations.
So
certainly could be other intracranial pathology as well.
okay.
So I think
before she came to you, the local doctor actually got this scan and sent her to you. Can you quickly describe what you're seeing?
Yes, this is a Chiari malformation. Looks like medulla is beyond the foramen magnum as well. So I guess this would technically qualify as a Chiari 2.
Okay. Maybe we'll address that in just a bit. What do you see on the axial view?
I should say 1.5. Looks like she's got some enlarged ventricles as well. Larger than I expect for age.
Right. So you're absolutely right. So as you know, a lot of these scans that are done locally in outreach clinics are not detailed scans. So this was sort of I would call a preliminary scan. But you're absolutely right. This is a red flag. She has ventricles that are certainly larger than usual, and you correctly pointed out the tonsillectopia. So you go back and you ask the mother, and the child. The mother actually now tells you that when the child was young, she had delayed milestones in the sense that she was slow as compared to the other siblings and holding her neck up, crawling, sitting, walking. In fact, she was so worried she took the child to the doctor. The doctor, the pediatrician, diagnosed her as having failure to thrive. She had really poor intake, and they actually had to put a G tube in her. And before they put a G tube in her, they actually got this scan. This was when she was 8 months old.
Okay. For some reason, I just cannot see this one as well on my computer. I don't know. At least from what I can see, it looks like the craniocervical junction looks normal.
Okay. So that's good. So Paul, maybe we'll pick on you. Excuse me. So you have a new scan when she's 12 years of age that shows tonsillectopia and maybe ventriculomegaly. That's a little odd. But when you look at the older scan, there's no evidence of tonsillectopia. How do you reconcile that? Maybe Paul is not there. Let's go to Niall.
Looking at this MRI, the structures, they all look very abnormal to me. And looking here, there's, some kinking at the medulla, and everything looks sort of superiorly displaced. So I don't know if there's some basilar invagination going on here. It looks abnormal. It's hard for me to put a finger on exactly what I'm.
No tonsillectopia on the scan that she had when she was an infant. Certainly some worrisome early milestone history. A healthy kid should not be needing a G tube to keep nutrition down. And a scan that doesn't actually show tonsillectopia at this stage, and the ventricles were actually quite small at that time also. And at that time, they also got a more detailed scan that, in fact, were interpreted as normal. So you've got a normal scan when she was 8 months old, with a history that suggests that she has some brainstem dysfunction. So now that she's 12 years old and she's sitting in your clinic, now we can do these really fancy dedicated scans where we look at flow through the CVJ. So we are running out of time, so maybe I'll just quickly go over this and pick on the residents for something else. So this certainly shows tonsillectopia. That's quite prominent. It shows that she has ventriculomegaly. This scan actually shows that her aqueduct may potentially be blocked. there seems to be a lesion within the aqueduct, and what the radiologist pointed out as potentially a lesion in the third ventricle. In full disclosure, two radiologists were convinced about this. A third one wasn't. But the question came around was that is the tonsillectopia primary or secondary? I mean, does she have hydrocephalus from a constellation of aqueductal stenosis and some intraventricular pathology that is leading to tonsillectopia, or does she have tonsillectopia that's giving rise to hydrocephalus? The second possibility is obviously a little hard to reconcile if you have some suspicion that she has an obstructive pathology sitting in her aqueduct. So, what do you want to do, young one? Are you there?
Yes, I'm here.
So, and these scans just show you in a higher resolution and zoomed up the lesions which the radiologist helpfully indicated with a green arrow.
Hello?
Yeah, go ahead. We can hear you.
Sorry, I couldn't hear you.
I'm just asking you as to how do you want to proceed given the constellation of imaging findings and her clinical presentation?
So yeah, her clinical findings are very concerning. So I mean, yeah, I don't know what is causing what, but she's definitely symptomatic from it. So I think that would warrant some type of intervention for her. She's having. Hello?
Yes, go ahead. What do you want to do?
So I guess you can decompress her and see if that helps her at all with the symptoms that she's having with her headaches and her cranial nerve deficits.
So we just have a few minutes left. So you've got an intraventricular pathology that's at least been radiographically identified, for which you don't have a clear-cut diagnosis. The radiologist is concerned that there is something at the aqueduct, and they documented that there is low flow through the aqueduct. It's not completely obstructed, but it's not completely open either. She's got ventriculomegaly. She's got tonsillectopia. Some of her symptoms match with the Chiari presentation, some don't. So the question is, what do we do? Maybe one last time I'll ask Vikas, what do you think we should do?
ETV.
Hello. So this is a perfect case, I think, for an ETV to explore that area of the floor of the third ventricle, and also to do another frontal burr hole to look at the aqueduct as well, and to both see if there's an actual tumor there, and also to allow flow for the CSF.
Yeah, I think that's exactly spot on. So you want to establish histological diagnosis, and since you have an obstructive pathology, she's actually a good case for an ETV. And then hopefully, if that's the primary problem, then the tonsillectopia will take care of itself. The reason why that initial image from childhood is important is for most of our children, or for that matter, adults, tonsillectopia doesn't just suddenly start one fine morning. Usually, if you serially scan them, we usually don't, but if you have more than one scan, the tonsillectopia is usually present. So the fact that it was absent when she was young and suddenly came around at 12 years of age when she's sitting in your clinic probably leans you towards thinking that maybe the tonsillectopia or primary tonsillectopia was never the problem, and maybe it's a secondary issue. So that's what we did. We did an ETV on her, and then interestingly enough, I tried looking around in her. I used a single burr hole. The ventricles were large enough, and I thought with a flexible endoscope, I should be able to reach back into the aqueduct. The floor of the third ventricle looked pristine around the anterior region. So very cautiously, after rechecking and checking with stealth, I took a couple of bites, which looked to be completely normal ependymal surface. And I'm glad I stopped there, because those biopsy results came back as normal ependymal lining. I was able to do a successful ETV. That wasn't a problem. We still haven't established a histological diagnosis on her. She actually got better, and her follow-up scans actually already show that her tonsillectopia is getting better. The tonsils have already moved up a few millimeters. All of her symptoms have resolved, and I think we still have to, at some point in time, re-explore what this pathology is. It does not necessarily fit into a profile of a high-grade tumor. A multifocal intraventricular low-grade tumor can happen, but I'm not sure if that's what the underlying reason is. So right now I'm just observing her. Her symptoms have gone away. Radiographically, she's better, and we'll keep a close watch on her. Uh, the the uh, the reason why I presented this case was to show how an ETV can be used in a somewhat atypical situation to achieve the purpose of CSF diversion. That's all what I have for today. 1 minute early. I can take a quick question.
It's quite a bit, though. It's quite a lot of material you've covered in 2 sessions.
I think the ventricular endoscopic anatomy certainly bears more elaboration. Benny, myself, and Andy have been working on some basic content, and I think maybe that's a good thing to reintroduce to the residents. It's not something that intuitively most people are able to pick up, reconciling the ventricular views with the gross anatomical views. So I think maybe we'll have some more sessions on that later.
That'd be great. Thank you.
All right. Thank you, everyone.